evening, everyone, and a very warm welcome for the webinar on OncoBridge 2025 Clinical Updates in Common Cancer, Lung, Hematology, and Breast Cancer. With immense pleasure, I would like to invite Dr. Asim Kumar Samar, who is Senior Consultant Medical Oncology at BMCHRC Jaipur, for the welcome and introductory note and to take the proceedings further. Over to you, sir.
Yeah, thank you. My voice is echoing. Just a second. Hello.
Yes, sir.
Yeah, now it's not echoing, no?
Yes, sir.
Okay.
So you need to log out from one device.
No. Actually, the thing is, I can see on my laptop and I am speaking and
Okay,
capturing
sir.
the.
Fine. Yes, sir.
So
It's
this
not.
will be the system. I'm so sorry for the technical glitch. So I wish to welcome all the speakers, esteemed doctors, for this wonderful meeting where we will discuss the science and the latest updates in the academics of the GI cancer first. And as you all know, the GI cancers are upcoming in a big way because of the immunotherapy has emerged in almost every setting, whether in the early therapy or in the adjuvant or in the metastatic sites. And we will discuss some eminent, you can see the abstract presented recently in the various conferences. And for that, we have almost all the, you can say the heroic speakers in the list. So first, I would like to invite. It is 7:05, right? So I would like to invite Dr. Lalit Sharma. He is my very favorite colleague. He is consultant in medical oncology in the Manipal Hospital, and he will be speaking on adjuvant chemotherapy or chemoradiation in the gallbladder cancer, a phase 3 randomized control study. There is accelerate trial. So, Dr. Lalit, are you there?
Yeah, good evening, sir.
Yeah,
Thank
good
you
evening. Good
so much
evening.
for
It's
that
very
friendly
nice to
welcome.
see you. Yeah.
So can I share my screen now?
Yes, please.
So I hope my slides are visible.
Yes, sir.
Okay. So at the outset, let me thank the organizers, especially Dr. Asim sir, for giving us all this opportunity to brush up our academics. And I would like to thank all the participants also for sparing their valuable time on a weekday for this academic event. So the job cut out for me is to discuss Accelerate trial. Now, Accelerate trial, this trial basically assessed adjuvant chemotherapy or chemoradiation along with adjuvant chemotherapy in gallbladder cancer. Now, gallbladder cancer, or for that sake, hepatobiliary cancers, they are common occurring in the third world setting, especially in our peninsula. Unfortunately, not much of research work has been done in these particular disorders, and because they are very not that common in the Western setting, so the data is very poor in these particular disorders. So far we have not been able to what shall I say, appropriatize the prognosis in these cancers. For first and foremost reason is most of the times they turn up to be in advanced stages at the presentation itself. Even if they turn up in an early stage, most of the times the surgeries are done in the non-optimal settings, and the role of adjuvant therapy has yet not been very precisely made clear due to the lack of the research. So this particular therapy trial, this wanted to look into the prospect of adding chemoradiation to the routine adjuvant chemotherapy, which we usually give for say around 4 to 6 months of perioperative period, and to look for what is the relapse-free survival in the resected gallbladder cancer when chemoradiotherapy was added to the standard adjuvant chemotherapy. So it was a phase 3 open label randomized control trial. The patient population was gallbladder cancer who were operated either R0 or R1 resection. They were randomized into the two arms. The observational arm received chemotherapy alone, that is kind of physician's choice chemotherapy, either in the form of GEMOX, day 1, day 8 every 21 days, or GEMSIS in the standard doses, day 1, day 8 every 21 days. The experimental arm, 3 cycles of chemotherapy. The patients were given chemoradiotherapy. The concurrent chemotherapy was in the form of capecitabine, and following which 2 to 3 more cycles of the adjuvant chemotherapy, either GEMOX or GEMSIS, was delivered. So chemotherapy options, as we discussed, were either GEMOX or GEMSIS, and the concurrent chemoradiotherapy protocol was that the radiation was given 45 gray in 25 fractions with concurrent capecitabine at 825 milligram per meter square twice a day on the days of radiation. Initially, the researchers planned for 100 patients per arm, because that this trial was conducted in COVID era and there was slow accrual. So only around 94 patients could be randomized. 49 were randomized in the observational arm and 45 in the experimental arm. The timeline was between April 2018 and January 2021. The median, as far as the baseline characteristics were concerned, most of the parameters were pretty well matched in both the arms. The median age was around 55 years, and most of the patients had an ECOG performance status of 0 to 1. The gender distribution was also pretty well matched, with around 32 females in each group. And all the patients, though initially they had planned for R1 resection also to be included, but all the patients had R0 resection at the time of enrollment into the trial. The treatment was completed, that is 5 to 6 cycles of chemotherapy was completed in more patients in the chemotherapy alone arm, that is 85.7%. In the experimental arm, where chemoradiotherapy was added, only around 62% of the patients were able to receive 5 to 6 cycles. Though these dose reductions or delays were kind of similar in both the arms. Somehow, there was more incidence of diarrhea and neuropathy in the chemotherapy alone arm, probably because the chemotherapy was given in a continuous fashion and there was no interruption as it was there in the chemoradiotherapy arm. So as far as the outcomes go, the relapse-free survival was not estimable in the observational arm, that is the chemotherapy arm, whereas in the chemoradiotherapy arm, it was 34 months. The overall survival was also not estimable in the chemotherapy arm. In the chemoradiotherapy arm, it was 34.5 months. The median relapse-free survival in the chemotherapy arm was 51.96 months, whereas in the chemoradiotherapy arm, it was 43.99 months. So to conclude, addition of chemoradiotherapy to chemotherapy, it did not provide any specific improvement in the outcomes, be it progression-free survival, relapse-free survival, or overall survival. Considering, at least so far, we can consider that chemotherapy alone probably is kind of sufficient. And though the kind of pitfalls or reservations of this particular study are that, one is that the sample size was not really very big, and maybe the most of the patients were R0 resection, which is usually not the real world scenario. We many a times do find that patients have R1 resection, and probably in those cases, RT might be beneficial, as it is kind of directed towards more local control. So, with this, I thank you all for your patient hearing, and I would like to hand over to organizers.
Yeah, thank you, Dr. Lalit. And just is because it's the abstract presentation, so would like to ask only one small question is, as it is, we are not referring patient for the radiation therapy after the extended cholecystectomy, where the nodes are removed adequately and the margins are negative. So it was the practice for the pretty long period of time, right?
Yeah, right, sir.
Yeah. And only thing where you rightly said is the margin positivity, or there is some dicey thing in the liver resection, then only we might consider for the RT. And where it is only RT, or you would like to send for the CTRT? What is your view, Malab? What is your practice?
So definitely CTRTs would be far better. The only reservation, if the patient is a very poor GC, then RT alone might be considered. But having said that, if the GC is that poor, probably that patient might not be eligible for a radical kind of dissection also and further therapy also. So wherever possible, definitely CTRTs.
Yeah. Thank you very much, Lalit, for sparing time in your busy schedule. And I guess you are in the clinic still. But thank you very much. Thank you for your nice presentation. So now I would like to invite our next speaker, Dr. Ankur Punia, and he is the assistant professor in Department of Medical Oncology and my good friend in the Mahatma Gandhi Hospital. And very often we meet and discuss the science. And now this is the platform where Dr. Ankur Punia will be presenting a good, you can see the uh, backwater trial analysis for the first line encorafenib plus cetuximab plus chemotherapy in BRAF positive mutant metastatic colorectal cancer. So it's very untouched niche of the patient where we find this kind of the population, and what to do with this kind of patient we even I don't know. So he will be throwing some light over this particular subset. So Dr. Ankur, to you.
Yeah, thank you, sir. Good evening to everybody. Thank you for this
Good evening.
inviting for me for this talk. So basically, I'm going to again discuss an abstract of a trial which was presented. It's a water break trial for upfront use of targeted therapy in BRAF mutated colorectal cancer. Basically, it's comparing efficacy of encorafenib with cetuximab along with the standard chemotherapy, which was modified FOLFOX6 in this arm against the standard of care for BRAF V600E mutated colorectal cancer patients in the upfront setting. So we know that BRAF is a mutation, not that much common, but it's a common mutation in metastatic CRC. Almost 10% of patient has it. And most of the patient, the results are not that much good. Standard treatment is to give chemotherapy. We can add a biological agent like bevacizumab, but overall outcomes are poor for this subgroup of patients. And encorafenib, along with cetuximab, has been approved by FDA for patients with metastatic CRC in the second line setting based on the Beacon study, which was presented a few years back. So based on that, this study was started in the first line setting in which they added this combination along with chemotherapy, comparing with the standard of care treatment which we give to these patients. So this is basically this early analysis shows us about the efficacy and safety of this triplet versus the standard of care of the therapy. So primary endpoint of this trial are progression-free survival and overall response rates. And this prelim first analysis tells us about these two primary endpoints only. So this is open label randomized phase 3 trial, patients with BRAF V600 mutated, no prior systemic therapy for metastatic disease. There are 3 arms. One arm only has encorafenib plus cetuximab, second arm encorafenib cetuximab along with FOLFOX6, sorry, and standard of care. Standard of care is usually FOLFOX or FOL3 along with targeted therapy, bevacizumab was also allowed. So this analysis basically it looks at the two arms of this triplet and standard of care. The arm comparing encorafenib and cetuximab has not been reported till now. So we look at the baseline, demographic, around 240 patients in both the arms. Majority of the patients are colon cancer. Majority are right-sided colon cancer, as BRAF is more common on the right side. 50% had a history of surgery, and you can see patients were MSI proficient, bar 1 or 2 patients. So we had the data for most of the patients, so they were not candidate for immunotherapy as well. So looking at the efficacy results, so this is again the overall response rates. You can see there is a marked improvement in the overall response rates, almost 50 times 50% more, 60 versus 40%. Look at overall CRs, though not we don't expect many CRs in colon cancer, but partial responses and were increased when giving this targeted therapy along with standard of care. So we have to look that around almost 17% patients had a not evaluable response in the standard of arm. So whether that might have skewed, we don't know, but still the responses were pretty high. An estimated median duration of response was 14 versus 11 months. At almost at 12 months, 22%, 11% patients were still on the treatment. So patients, it was helping almost 20% of the patients were having a long-term response with this combination. We look at all the subgroups, all the subgroups benefited by addition this targeted therapy, whether they were age was more less than 65, more than 65, male, female, good performance status, number of baseline metastases, whether left-sided or right-sided tumor, whether liver mets present or not. All the subgroups benefited by addition of this targeted therapy to the chemotherapy. So this is the overall, survival rates. At 12-month OS is better. It's 80% versus 66%, but median is still not reached in the, in the experimental arm. So it's a primary analysis. We might have this, definitive OS results at the final analysis of this trial. Okay, if you're looking at the adverse events, because we are adding more therapy to the patient, so obviously the adverse events will increase. The most common adverse events were nausea, anemia, and diarrhea. And grade 3 for adverse events were obviously higher with the targeted therapy. They were almost 74% versus 61% in the standard of care of arm. So, but serious grade 5 adverse events were more or less same in the tune of around 4%. Discontinuation was seen slightly higher, 20% in the experimental arm versus 15%. Dose reductions were seen in majority of the patients, almost 85% patients in the experimental arm. That is quite expected when we use two kind of targeted therapy along with the chemotherapy. Looking at treatment-related adverse events, again, grade 3, 4 were higher, 70 versus 54%. Serious adverse events were more or less same. Discontinuation was seen and dose reduction was seen as expected in all, whether there was targeted therapy or other chemotherapy drugs. But obviously, they were more with the experimental arm. As already told you, nausea, and, anemia, and diarrhea are the most common adverse events. But if you look at this, grade 3 or more adverse events were most commonly anemia or decreased neutrophil count. Nothing new was seen, which we don't know about this drug. So nothing major has been seen. But yes, obviously toxicity increases by adding more and more drugs to the therapy for the patient. So basically, to conclude, by giving a combination of encorafenib with cetuximab along with standard of care modified FOLFOX6, there was statistically significant improvement in the overall response rates, almost 60 versus 40%. There was improvement in the progression-free survival. There was a trend towards improvement with overall survival as well, but mature OS and PFS still awaited. Toxicity profile, we know, which we have already seen, nothing new was seen, though there was increased adverse events, but there were dose reductions and discontinuations were seen, but there was no substantial increase. So based on this, investigator concluded that this supports the use of this combination as a first-line treatment for BRAF mutated CRC. And based on this, it has received affiliated FDA approval as well. Thank you.
Thank you, Dr. Ankur. So, as it is adding cetuximab to the what you call is any protocol added to the side effects, and sometimes the cetuximab side effects alone are also very difficult to handle. And adding to the encorafenib with this combination, I guess in our imagination it will be tough to handle. What do you say?
It will be pretty tough, sir, because as such, I rightly said, almost 50% of patients are not able to even tolerate cetuximab properly. And we had another agent which is not that much safe. It has its side effects. So it will be pretty toxic. So maybe, very, very good performance. Young patients might be the ideal candidate, but still it will be tough to give, proper treatment throughout to the patient.
And with the when there is a deviation from the trial doses, we don't know how effective the regimen is. So
Yes.
it might not be very practical thing to do in the clinics, but still they have discovered or explored the other option, which may be useful in the future. So thank you very much, Dr. Ankur. Thank you. And now we move towards the next topic. And for that, I would request Dr. Rohit Swami. He is a consultant medical oncologist in the Narayana Multispeciality Hospital, Jaipur. And he will be speaking on the intraperitoneal and intravenous paclitaxel plus S1 versus intravenous paclitaxel plus S1 in gastric cancer patient with peritoneal metastasis, result from the multi-centric randomized phase 3 uh, Dragon trial 01. So
Yeah,
Rohit,
good evening, sir. Good evening, everyone.
good evening.
Can someone please share my slides?
Technical team, please.
Sure, sir, I will share. The slides visible, sir?
Yeah, visible. Okay, so good evening, everyone. I will be presenting Phase 3 Dragon 1 trial, which is a Chinese trial which compared efficacy of adding intraperitoneal paclitaxel with IV paclitaxel and S1 in metastatic gastric cancer patient with peritoneal metastasis only. Next slide, please. Next slide. So coming to background of this study, so as you all know that most common site of gastric cancer is peritoneal metastasis, and the patients having upfront peritoneal metastasis has a median survival time of around 6 to 15 months. Not much options are available with these patients except chemotherapy or immunotherapy addition or HER2-directed therapy addition. And none of the treatment guidelines at present has incorporation of intraperitoneal chemotherapy along with systemic therapy. And several phase 2 studies as well as a single one phase 3 study has shown that intraperitoneal chemotherapy can give or add the benefit of IV chemotherapies or oral chemotherapy. Like several phase 2 studies has shown that the conversion surgery rate, that is, after the complete response in the peritoneal metastasis, going for surgery in surgical resectable cases, conversion surgery rate can reach as high to as 80%, R0 resection rate can reach as high to as 70%, and giving median survival time to these patients with peritoneal carcinomatosis upfront, median survival for survival time more than 40 months. So one phase 3 study was conducted in China itself, which was Phoenix gastric carcinoma trial, which compared intraperitoneal paclitaxel along with oral S1 and IV paclitaxel versus cisplatin plus oral S1. Median survival time in intraperitoneal arm was around 17.7 months as compared to 15.2 months in IV plus oral arm only, with hazard ratio of 0.72. So there was numerical benefit on overall survival, but there was no significant survival benefit in this study. Next slide, please. So median survival time was 17.7 months in intraperitoneal arm as compared to 15.2 months only. And with the additional 1 year follow-up, as we can see at the 3-year overall survival rate was around 21.9% in intraperitoneal arm as compared to 6% only in oral as well as IV arm. So this phase 3 study showed us that there can be numerical benefit in survival with the addition of intraperitoneal therapy along with the conventional therapies, though this study didn't show any significant benefit in overall survival. Next slide, please. So this phase 3 study was conducted which compared intraperitoneal paclitaxel along with the systemic therapy as compared to IV paclitaxel and oral S1. So this was the first case of this study which was randomized in the intraperitoneal arm. This was 39-year-old female with the peritoneal carcinomatosis index of 30, very heavy peritoneal metastasis burden. Next slide, please. And after receiving intraperitoneal chemotherapy along with IV paclitaxel and oral S1, there was complete response, and this patient underwent conversion surgery, leading to increase in her median overall survival. So this was second staging laparoscopy, which was done after the completion of 4 cycles of intraperitoneal paclitaxel along with IV paclitaxel and oral S1, and this showed complete response. Next slide, please. So, several phase 2, phase 3 studies has been conducted incorporating intraperitoneal therapy along with the standard of care in the China in several centers. There are several phase 2 studies which had incorporated intraperitoneal paclitaxel, oxaliplatin, as well as cisplatin in different studies. Next slide, please. And the standard of practice of these patients incorporating intraperitoneal therapy is to give 3 cycles of intraperitoneal therapy along with the IV therapy as well as oral therapy. Intraperitoneal and IV therapies are given on day 1 and day 8 of 21 days cycles. Oral S1 is given for 14 days, followed by 7 days of gap. So 21 days, 1 cycle, and after 3 cycles, patient is assessed for conversion surgery. And the indication for conversion surgeries are complete response in peritoneal mets laparoscopically, and if the primary tumor is resectable or not, and cytology previously positive becomes negative, and there are no other distant metastases. Coming to next slide. So coming to our study design, patients were randomized in 2:1 fashion in intraperitoneal arm and in conventional treatment arm. So intraperitoneal arm received IV intraperitoneal paclitaxel 20 milligram per meter square on day 1 and day 8, IV pacli 50 milligram per meter square day 1 and day 8, and oral S1 80 milligram per meter square from day 1 to day 14. And there was no intraperitoneal arm in paclitaxel and oral S1 arm, though paclitaxel dose was increased to 70 milligram per meter square in this arm. Primary endpoint of this study was overall survival in intent to treat population, and secondary endpoint was conversion surgery rate, pathological response, and adverse events. So, as you already discussed, the intraperitoneal as well as IV chemotherapy was given on day 1 and day 8, and oral S1 was given for day 14 every 21 days. Next slide, please. Key eligibility criteria were upfront metastatic adenocarcinoma gastric cancer with only peritoneal mets, no other mets. PS0, PS1 patient between the age of 18 to 75 years with adequate organ functions. Rest other all patients are excluded from screening. Next slide, please. Next slide, please. So this is a concert diagram of this study. Around 246 patients were screened and around 148 patients were included in intent to treat population in intraperitoneal arm as compared to 74 patients in intent to treat population in conventional treatment arm. Patient enrollment was done from May 2017 to March 2022 with median follow-up of around 60 months. Next slide, please. Baseline characteristics were well matched in both the arms. Around 50% were male and 50% were females, and all the patients were of ECOG 0, 1. Coming to histology of these patients, so around 60% of these patients has the well differentiated or poorly differentiated adenocarcinoma. Around 40 to 50% of patients had signet ring cell carcinoma, which has very poor prognosis, and around 5% of patients had mucinous adenocarcinoma. Coming to the burden of disease, so according to peritoneal metastasis Japanese classification, the stage P1C, around 50% of patient has the P1C, that is higher burden of disease, a higher burden of peritoneal metastasis, and peritoneal cancer index from 1 to 10, 11 to 20, and 21 to 39, 30% were 30% patients were equally divided in all of these three arms. Peritoneal cytology positive was seen in 50% of patients, and negative on starting treatment was in another 50% of patients. And around 60% of patients has less than 300 ml of ascites, whereas around 35% of patients has moderate to gross ascites from initiation of therapy. Next slide, please. Coming to primary endpoint of this study, there was significant overall survival benefit in the intraperitoneal arm. Median overall survival was 19.4 months as compared to 13.9 months in conventional arm. And 1 year overall survival probability was around 70% in intraperitoneal arm as compared to 54%. And even 5-year overall survival was 11% as compared to 7.9%. So this benefit of survival was maintained uh, for a very long period with a hazard ratio of 0.66. Next slide, please. And the survival benefit was maintained throughout all the subgroups, whatever the burden of disease was there. Previous slide, please. Whatever the burden of disease was there initially, even in the PCI of more than 20 as well as PCI of less than 10, whatever the histology was there, even there was significant survival benefit in the signet ring cell pathology as well as mucinous pathology. And conversion surgery, patients either going in conversion surgery or not able to fit the criteria of conversion surgery also had survival benefit with intraperitoneal therapy. Next slide, please. So coming to conversion surgery rate, so it was significantly higher in the intraperitoneal arm. 50.7% underwent conversion surgery as compared to 35% in conventional arm only. And even in both of these arms, the patient who underwent conversion surgery had better survival as compared to patient who were not able to undergo conversion surgery. So median survival in the patient with conversion success was 33.1 month as compared to 11.1 month in conversion failure patients. Similarly, the patient who received conventional therapy only, this conversion success median survival was 18.8 months. So there is a vast difference of 33 months as compared to 18.8 months. Next slide, please. And the patient who underwent R0 resection in both the arms. So the patient who underwent conversion surgery and also had the R0 resection post-conversion surgery has better median survival in both the arms as compared to the other patient who underwent R2 resection or no resection. And this magnitude of survival benefit was much higher in the patient who received intraperitoneal therapy. Next slide, please. Coming to adverse events, so both the adverse events in both the arm were almost comparable. Even the hematological as well as non-hematological side effects were almost similar. Grade 3, grade 4 side events were also similar in both the arms. Next slide, please. Though there were port-related side effects in intraperitoneal arm, so around 4 patients had port site infections, and a few patients had reflux or subcutaneous accumulation of the drugs, and one patient had subcutaneous seeding of these cancer cells. Next slide, please. So limitation of this study is that this was conducted only in Chinese population. Asian population can't be generalized throughout the globe. And second thing is that the systemic chemotherapy, which was involved in both the arms, were of the standard of care of the year of 2017 when it was started randomizing. Now we have multi-drug combination like FLOT and other chemotherapy regimens for gastric cancer. Next slide, please. So key takeaway point is that intraperitoneal route of administration of drug can be very much beneficial in these patients which have peritoneal metastasis only. And this intraperitoneal addition of chemotherapy along with the IV chemotherapy and oral chemotherapy can give us robust response rate, can give us good survival benefit, significant survival benefit, and can also increase our conversion surgery rates along with the patient who undergoes conversion surgery and R2 and R0 resection can receive the maximum benefit out of this intraperitoneal chemotherapy addition with median survival reaching up to 50 months. Next slide, please. So summary of this study is that the patient who underwent neoadjuvant intraperitoneal therapy along with the systemic IV paclitaxel as well as oral S1 as compared to conventional IV paclitaxel and oral S1 therapy, there was significant survival benefit. There was increased conversion rates, increased conversion rate of R0 resection, and increased median survival benefit. So this study may be treatment changing study, though further study including the global population has to be done at a larger scale to come to any conclusion or to change the treatment guidelines. So I'll conclude my talk here. Thank you.
Yeah, thank you, Dr. Rohit. The data are impressive actually, and this, gastric cancer who are spreaded and the interpenetrating surfaces very difficult to deal with. But it's a kind of dream where this kind of the treatment will be successful. So the data are very impressive, and we know in the ovarian cancer also intraperitoneal chemotherapy has shown very good
Benefit.
benefit, but
Yeah.
still it is not in the common practice. But
Yes.
I think only the technique is difficult to handle. Otherwise, there is a science behind it, no doubt. So it's a very good study. Thank you very much, Rohit, for sparing time. Thank you. And now
Course.
we will move towards the next abstract presentation. And for that, I would invite Dr. Rohit Ribello. He is from Udaipur, our good colleague and very good friend. He is a consultant and HOD of the Medical Oncology Department in the GBH Memorial Cancer Hospital, Udaipur. And he will be speaking on the tumor-free ctDNA detection as a decision tool to support organ preservation in node-negative rectal cancer undergoing neoadjuvant chemotherapy, excision, and observation in the phase 2 NEO trial. So for that, I would invite Dr. Rohit Ribello once more. Dr.
Thank you.
Rohit?
Thank you,
Yeah.
sir, for inviting me to give this talk. We'll just get started quickly. So next slide. Next slide, please. Yeah. So the background of this study is actually, it's a phase 2 study where they've taken T1 to T3 low and mid-rectal adenocarcinomas and given them 3 cycles of neoadjuvant chemotherapy. The primary aim of this was to go in for a transanal endoscopic surgery 2 to 6 weeks later so that they can see the organ preservation rate. But going ahead, they also had collected samples and for ctDNA studies. So the protocol specified organ preservation rate was 57 because 13 patients declined surgery out of the 26 that actually required surgery post neoadjuvant chemotherapy. So that resulted actually in an organ preservation rate of 79%. In spite of this fact that 13 patients did refuse surgery and the other 10 patients who actually went for surgery, 7 of them were actually found to be in pathological complete response with no tumor present at the time of surgery. So very impressive study on organ preservation in rectal cancer with a 3-year disease-free survival of 94.7%. But there's some limited data. Obviously, we all know about the bespoke study. So the bespoke study is something that helps us use ctDNA in colon. That's also a phase 2 study that has been recently published and seems very interesting and seems replicable in the clinical context. But in rectal cancer, this is the study that gives us an idea on where ctDNA can be used. Next slide. So what they did is they collected plasma which was retrospectively analyzed in with the Guardant Reveal assay. They leveraged about 20,000 epigenomic regions for the ctDNA. They took samples before chemo, after 3 months of chemotherapy, every 12 months for 3 years during survival, and on progression whenever available. Next slide, please. So what they found was in the sensitivity in the T1 stage was 14%. In T2, it was 53%. In T3, it was 44% the sensitivity of detection. ctDNA detection was lower following neoadjuvant chemotherapy. That is, only out of the 6 patients, only 4 patients actually showed ctDNA positivity after chemotherapy. And if you look at the graph on the right-hand side also, what you will very clearly see is that 49% had undetectable ctDNA at both time points, 44% had reduced tumor burden, and only 7.3% actually had increased tumor burden. So if you look at the next slide, you see the post-chemotherapy pre-excision detection of ctDNA. One can see that only 4 patients actually had it detected post-chemotherapy and pre-excision. Next slide, please. Next slide. So if you look at the 3-year recurrence-free survival, next slide. If you look at the 3-year recurrence-free survival, it is 90% versus 88.5% in those patients with the ctDNA status piece pre-chemotherapy. And if you look at post-chemotherapy, patients who had ctDNA positive post-chemotherapy had a inferior 3-year recurrence-free survival with a hazard ratio of 2.82. So one of the two next slide, 2 total relapses occurred in patients managed with TES were detectable by ctDNA. They had a low rate of false positivity seen on surveillance. Next slide. The limitation of the study was it was small, had a low event rate, and of 5 relapses. And so the prognostic differences based on ctDNA were difficult to detect. Plasma samples are only available once every 12 months during surveillance. These limitations may result in underestimating the sensitivity and lead time for recurrence prediction. This is particularly important when assessing the utility of ctDNA to guide organ preservation among patients with declining TME, as they had the greatest risk of recurrence and may benefit most from the additional decision aid. Next slide. So the key points or conclusions are in patients with T1 to T3 low or mid-rectal cancers undergoing neoadjuvant chemotherapy, followed by transanal excision for organ preservation. The ctDNA detection was detectable in 45.8% of patients before chemo and only 8.7% of patients after chemo. Detectable ctDNA after neoadjuvant chemotherapy was associated with poor response and persistent cancer. Further studies are still warranted to understand whether ctDNA has clinical utility in selecting patients for organ preservation. Next slide. So one more important point that we need to also consider is that the bespoke study has shown a significant benefit with a hazards ratio of almost about 20. So ctDNA is something that we have coming into the picture. And the other one important thing that is there in this particular study is there's a neo-RT study where they're trying to figure out if neoadjuvant chemotherapy or chemoradiation with ctDNA can be used to predict organ preservation in rectal cancer and completely avoid surgery. So ctDNA is here to stay. And I think this is the future of medicine, of deciding further therapy based on the presence or absence of ctDNA. With that, I would like to end my talk. Thank you.
Yeah, thank you, Dr. Rohit. Thank you very much. So and I guess every clinics or every week the lay person are coming and meeting us for the cell-free DNA and ctDNA. I think the clinical utility is yet to explore, but still uh, they are finding their place in the clinical practice. So thank you very much for enlightening the talk. And now I would like to request our dear colleague Dr. Pulkit Nag for the next topic. He will be presenting in first results of the nivolumab plus ipilimumab versus nivo monotherapy for microsatellite instability high micro MSI high or just a minute high or MSI deficient metastatic colorectal cancer for checkmate 8SW. So Dr. Pulkit, over to you.
Good
Say
evening,
more
sir,
on
and
topic.
thank you for the opportunity, sir.
Good evening. Good evening.
Sir, my slides are visible?
Yes, yes, and you are also visible.
Okay, thank you, sir. So I'll just straight away start with the sir has already indicated regarding the highlight of the topic. And so we are comparing basically nivolumab plus ipilimumab versus single agent immuno in MSI high and deficient MMR metastatic colorectal cancer, that is checkmate at 8HW trial. So we all
Yes.
know that around 4 to 7% of the metastatic colorectal cancer are MSI high or driver and associated with poor outcomes when treated with chemotherapy or target therapy. So initially, Keynote 177 study have showed improved PFS with first-line pembrolizumab versus chemotherapy for MSI high and deficient MMR metastatic CRC, but there was primary disease, progressive disease occurred in 29% of the patient. So the progression-free survival at 2 year and 5 year were 48% and 34%, suggesting treatment with more durable response is needed. So it was the unmet need at that time. So there was a non-randomized phase 2 checkmate 142 trial suggested overall response in PFS with Nivo and Ipli versus Nivo alone in an indirect comparison. There was not a direct comparison in that. In that, the single agent nivolumab role was established. So the checkmate 8HW was a randomized phase 3 trial that compared Nivo plus Ipli versus Nivo and versus chemotherapy for MSI high in deficient MMR stage 4 colorectal cancer. So the comparison shown that there's an improved PFS with the first line Nivo plus Ipli versus chemotherapy. This trial has already been published as a full stage paper. In today's abstract, we're going to discuss how the comparative arms of dual agent immuno with single agent immuno has worked. So this was the randomized study design. We can see the inclusion criteria, that is unresectable or metastatic CRC with or without prior treatment, with MSI hair deficient MMR with the ECOG performance status of 0 to 1. And the comparative arms were nivolumab 240 mg plus ipilimumab 1 mg per kg every 3 weekly for 4 doses, followed by nivolumab 480 mg every 4 weekly. The comparative arm is 2 raised to 2 raised to 1, that is the nivolumab is 240 mg every 2 weekly for 6 doses, followed by nivolumab 480 mg every 4 weekly versus investigator choice of chemotherapy. In today's abstract discussion, we are going to discuss only the dual agent IO versus the single agent IO response. The co-primary endpoint, the major endpoints, the follow-up of the treatment arm was until 2 years of disease progression or unacceptable toxicity, and the co-primary endpoints were progression-free survival across all the lines by blinded independent central review, and also immuno plus chemotherapy. The secondary endpoints were overall response rate and health-related quality of life, overall survival, and safety. So this was the various comparative arms. Like the median age was around 60 years. The female to male ratio, more of the females, the different parts of the world, more majority of them are in ECOG performance status 0 to 1 with liver and peritoneal mets. Majority of the patients are MSI high and deficient MMR, although fewer patients of MSS and proficient MMR were also included. In the good point about this trial, it has included the response in all BRAF, KRAS, and NRAS mutation, and also the clinical history of Lynch syndrome was present or not. So these were the baseline characteristic of checkmate 8HW trial. And I'll straight away come to the point that the 36-month rate, we can clearly see in the clear separation of the graph from Nivo, Ipli from Nivo, and the median progression-free survival benefit was 54.1 versus 18.4 months with a very significant p-value of 0.0003. So we can see that the separation of the graph is maintained until even till 50th month. So I think it's a very good response rate in view of dual agent IO versus single agent IO. Now, if we talk about the various subgroup analysis, overall in all the patients, whether irrespective of the age, sex, or the region or the ECOG performance status, even the tumor sidedness has shown good response. Even in the liver metastasis, the response is greater because initially in Keynote 177 trial, when single agent Pembro was tried, the response was not very good in the liver metastasis. But in this condition, even in liver metastasis, the response of dual IO is very nice. So we can see that in the right hand side, irrespective of TDL1, the response is good, and also irrespective of BRAF, KRAS, or NRAS mutation. If it is deficient MMR or MSI high, then the response is sustained with the help of dual agent IO as compared to the single agent IO. So I think this shows that irrespective of any subgroup, the dual agent IO in this particular category of patient has given good progression-free survival benefit. If we talk about the overall response rate, the difference is 71 versus 58 with a significant p-value of 0.001. The complete response is 30 versus 28, partial response is 40 versus 30, stable disease is 14 versus 19, and progressive disease were only 10 in dual agent IO, whereas is 19 in single agent IO. The duration of response in both these groups were not reached. If we talk about the health-related quality of life, it was positive at all measurements after baseline in both the arms, and Nivo plus IPRI arm reached the pre-specified threshold for a meaningful change at week 21. So obviously, we all know that the anti-PD-1 and anti-CTLA4 combination has led to more side effects. We can clearly see that the grade 3 treatment-related adverse effects was more in Nivo plus Cipri, that is 78 versus 50. If we compare of any grade, that is also almost double in dual agent IO. And the treatment-related death there were two in the Nivo Ipli arm, whereas every single death was then in single agent Nivo arm. So this was the major hindrance to use a dual agent IO is always the side effect profiling. And we can clearly see that the treatment related reported in greater than 10% of the patients are pruritus, diarrhea, hypothyroidism, asthenia, and fatigue and hyperthyroidism. These are the top five dual agent IO. In my respect, in personal patients in which I have used, the rash and fatigue are the most common side effects I have seen in dual agent IO. So the conclusion is the data from first result of the phase 3 checkmate 8HW study shows significant PFS improvement in outcome with Nivo plus Ifli in colorectal cancer across all category of patient. The Kaplan-Meier curve separated early and remained consistent after the first measurement. The 2-year PFS rate was 71 versus 56. The 3-year was 68 versus 51. The PFS improved with Nivo plus Ifli across all groups. It is associated with higher overall response rate of 71 versus 58. Nivo plus Ipli associated with higher rate of grade 3, grade 4 treatment adverse effect, but no new safety signals, and health-related quality of life improved in both the arms, and Nivo Ipli reached a meaningful improvement at week 21. Thank you so much.
Thank you, Pulkit. It is you can say the great combination where Nivo and EP can be used. The only problem is where to find this kind of the patient who are MSI high,
Yes,
right?
sir.
So
Right,
it's
sir.
it's a very narrow segment of the patient where we can use it, and I honestly say it's very difficult to find out this kind of the patient. But
Only
still,
7 to 8% of the patients we can find MSI high and deficient MMR. Sir.
yeah, 7 to 8 where you do the 100 patient test, but we are
Absolutely.
doing the test in the 7 to 8% of the patients. So how far our dream is, you can imagine. So
Absolutely.
thank you very much, Pulkit. But
Thank you,
still,
sir.
the data are very impressive. Wherever you find or we find the patient, it needs to be started like this only, Neo and EP, and
Thank you, sir.
I guess in some afterwards you can have the result of immunotherapy versus chemotherapy also in this trial. So there may be wide gap in this, right?
Sir, I think the full paper of the
Yeah, it
dual
is.
agent immuno plus chemo is already being published, sir.
No, no, no.
No, in the NEGM, it has been showed, sir. The graph are beautifully separated of Nivo plus Ipli versus chemo. It is a part of this trial only, sir.
No, no, but okay, we'll see that. And
Yes.
now I would like to invite our next, you can see the panel discussion where the moderator is Dr. Aditya Murli, and he is a senior consultant medical and hemato-oncologist in the Apollo Hospital, Bangalore. So I would like to request Dr. Aditya Murli to just invite your panelist.
Thank you so much, Dr. Asim Samar, and thanks to the organizing team for calling me. This is a topic which is quite close to my heart, and we ourselves were involved in doing a meeting on GI updates recently. So hopefully I can translate some of my learnings from there onto this particular platform. I am quite happy to have a very learned set of colleagues with me. If we can just acknowledge yourself, Dr. Abhishek, are you around, sir?
Yes, sir, I'm there, sir. Dr. Abhishek Charan.
Great. Dr. Abhishek Sharma.
Yeah, I am also here.
Great. Dr. Rahul Rai. Okay. Dr. Manish Gautam.
He's there.
Dr. Manish Gautam is there. Okay, great. Dr. Sachin Jain. Do we have Dr. Sachin Jain with us? Okay.
Please contact him. Contact him.
Okay. Do we have Dr. Siddharth Turkar with us?
I'm here.
Okay, great. So we have Dr. Abhishek Charan, Dr. Abhishek Sharma, Dr. Siddharth, and Dr. Rahul Rai with us, correct? All right.
Yes.
Great. So let me start off. Let me share my screen now. So over the next 20 odd minutes, I'm not going to discuss the same abstracts primarily because, I'm not going to talk about the results from the same abstracts. What I'm going to try and get a sense of is we've got this wonderful set of clinicians who practice these things in the clinics every day. So I want to try and get their take on this. The abstracts which I would like to cover include Accelerate, Breakwater, Dragon 01, Neo, and Checkmate HW. So proud to talk about Accelerate first. This is by Professor Atul Sharma's group from All India Institute of Medical Sciences. Lot of hard work has gone into this, and we should all be proud about this paper. But let me start with you, Dr. Abhishek Charan. In your practice, for resected biliary tract cancers, what is your go-to choice of adjuvant therapy?
Sir, for me, I prefer single agent capecitabine on the basis of BILCAP trial. And I prefer this only, sir, as of now. I've tried CTRT in one patient. I've tried JAMCAP also, but so far I have been comfortable in capecitabine because the results are good. Second, patient is able to complete the 6 months of therapy. So I have seen other patients, they are having toxicity, side effects, and they are not able to complete the therapy. Plus, they had the progression also. So in my limited experience, I would go for capecitabine.
So that's a wonderful point that you brought out, Dr. Abhishek Charan, that patients are able to complete capecitabine. The nagging fear in our minds is always, is capecitabine alone enough? Dr. Abhishek Sharma, over to you. Is there any circumstance where you want to add a double agent or a IV protocol?
Yes, sir, definitely. Because when you talk about the gallbladder cancer, definitely incidences in India is most. But when you talk about the data is definitely not so good from India. And when we have a study of BILCAP definitely suggested of those who are resected biliary tract cancer. BILCAP basically consider patient from T2 and onward patients, T1B also included, and node positive patient. The great benefit seen in node positive patients. But when you see the especially Tata data, this is the retrospective data that done in the biliary tract cancer with the gemcitabine and cisplatin as well as coxyliplatin for the patients. So they have some good PFS as well as overall survival when you go for retrospectively when you see this. So yes, I am on for GEMSIS for patients those who have a high risk factor, especially node positive. I definitely choose doublet on the good retrospective data as Indian data. You can say that.
Okay, so that's a very fair takeaway, Dr. Abhishek. So in node positive, adding a second agent or doing a GEMSIS is fine. Dr. Rahul, are you around? Can you hear me?
Yes, sir.
Yeah, Dr. Rahul, if I want to give you a choice of GEMSIS versus GEM-OX, what would you choose and when would you choose?
So, sir, either of two can be used, either gemcitabine, cisplatin, or oxaliplatin. There are some data which shows that the platinum's analogous platinum has similar result with gemcitabine. The only thing is if the patient is tolerable for cisplatin, we can go with gemcitabine and cisplatin. Otherwise, it is GEMOX. When toxicity and age and other comorbidities are concerned, then GEMOX is the preferred choice.
So great. So the third big takeaway from this discussion is if patient is cisplatin ineligible for some reason, be it age or comorbids, then GEM-OX is a reasonable thing to do. Dr. Siddhartha, last question on this particular topic. Um, would you want to use CTRT or when would you want to use CTRT?
So CTRT I would use only in those who are margin positive where resection is not possible and patient is fit enough to tolerate CTRT. Otherwise, I would not like to add CTRT in most of my patients.
Great. So to summarize the adjuvant spectrum for biliary tract cancers, the go-to would be capecitabine, given we have some phase 3 data for it. But if we have node positive and if in Indian patients who do tend to do much worse than Caucasians, GemCis is reasonable. If patient is cisplatin ineligible, maybe we would want to go to GemOx, but CTRT, I think those days are out more or less. Moving on to the next abstract that we have. Breakwater. Again, the beauty of this was a first line study in a BRAF V600E mutant metastatic colorectal cancer. This compared encorafenib cetuximab versus EC plus FOLFOX, M-FOLFOX6 versus standard of care. We have had this, we have seen this slide also. So I'm not going to repeat this. Let me start with the first question. Dr. Abhishek Charan, your take on this study.
So it looks promising, but the only issue that BRA V600E, I mean, it's a very rare entity. So, I mean, and the patient profile also, I have in my encounter, what I have seen, the patient PS is not that, I mean, it's not that good to give triple agent. So it will be good to see how it comes out. As of now, it looks promising, sir.
So, so I think the next one's for you, Abhishek, Dr. Abhishek Sharma. The question which I have is V600E versus V600F. How many times? I'm sure you test all patients for BRAF in colon cancer. In the last 2 years, how many BRAF positive patients have you seen, Dr. Abhishek?
Yes, sir, definitely. So BRAF percentage is low in our all CRC population, but this is the subgroup. Their survival is worst in all subgroup, definitely. So definitely we have some unmet need for this patient to improve. Any chance we can improve their survivals. I in my current practice, uh, this is only less than 1% patient I have seen of BRAF positive patient in my current study. And for this study, this is definitely a very good study because you are choosing the patient those who have a worst in their survival. But yes, data is still immature, you can say, in PFS as well as OS. And this study primary endpoint is dual primary endpoints. One is the overall response rate, one is the PFS. And yes, overall response rate is quite promising in this trial, but still we don't have any OS benefit as well till now because PFS is not mature, OS is not mature. But yes, we can use in our patient those who have a worse in a BRAF, definitely.
So, Dr. Rahul Rai, if I can just go back to the study, if you see over here, there was a dual primary endpoint of PFS and overall response rates. Now, so much of noise is being made. If I can use the word noise, is being made about the fact that overall response rate has come quite positive. What is your take on using ORR as a primary endpoint? And more importantly, how important is something like an interim analysis? Dr. Rahul, this one's for you.
Okay. So, I mean, overall response rate in a metastatic setting, yes, it is a bit tricky. Maybe in a neoadjuvant setting, it is a better, it can be a better primary endpoint. But for metastatic setting where, for us, even stable disease, PR or CR, everything is important. Overall response rate usually ignores the stable disease part and it usually includes only PR and CR. So, but for metastatic setting where we just want to prolong the survival of the patient, only overall response rate would not cover that the complete picture of the treatment. So PFS is a good endpoint, but overall ORR is yes something which is I'm not sure, but as they have used, so we can say that it is useful here.
Okay, I think that that's very well summarized. So, is it, I mean, is it fair to conclude that for some reason, if the patient does not want chemotherapy, so let's not talk about cost or availability. We don't have access to Encurafenib in India, so that might be a little bit of a moot point. But is it fair to say that tomorrow morning, if you have a BRAF V600E mutation patient with us, you would give the EC combination or EC with chemo, or how would you go about it? Dr. Rahul?
Yeah, sorry, sir, I didn't get your question. Sorry.
So no. What I was asking was, has this trial made you change your practice from chemo to a targeted approach in BRAF EE mutation patients?
I mean, sir, I would still wait for the much mature results, because even the FOLFIRINOX with bevacizumab, that drug also combination has also a very good response rate and survival outcomes. So for this, yes, it's a choice which is available with us, but I will wait for much mature results before trying this drug. In any case, it is very costly, so I don't think even 1% of my population would be able to, take this drug.
No, I agree with you on that. Absolutely, very fair. Dr. Siddhartha, this one's for you. The question which I have is, let's say you have a V600E mutant patient on one hand, and you got a MSI high patient on the other hand. Would you pick a IO or would you pick a targeted approach?
I would pick an IO.
Um, didn't even think so. Fantastic. Okay, great. Any reason for this?
So, like we have seen that these patients with MSI high has pretty good response rate IO, and even in those patients, we are the possibility of having BRAF and MSI high is very high. So we are going to choose that they have lesser toxicity, and there is also a trial ongoing with this where we are trying this combination along with pembrolizumab also. So right now, my choice of drug is pembrolizumab for MSI high.
But rightly pointed, Dr. Siddhartha. What will be interesting to see is the Pembro EC combination. So we'll talk about the HHW a little later.
Trial has excluded the MSI high patients.
Yeah, I was about to say that 8HW. Yes, that's correct. That's correct. So moving on to 8HW, this was just discussed. Okay, I'll start with, I'll go back to you, Dr. Siddhartha. You talked about pembrolizumab. Why Pembro or why not Nivo EP?
So I have more experience with pembrolizumab regarding toxicity profile. Ipilimumab, most of my patients have not able to afford, so I have not given it to many patients. So comfort zone is more with pembrolizumab. That is one reason. Apart from that, in this trial, we have seen there is pretty good responses. So I think the combination, dual combination is good when we really thinking towards controlling the disease for very long term. But we don't have head-to-head trials. So like that is the only reason.
So to reiterate Dr. Siddhartha's point, the median follow-up for Keynote 177 was 73 months, 70 to 73 months. So that's a very long follow-up, and there is of course the comfort level of the dosing and everything. I'll be coming to you now, Dr. Abhishek Charan. Nivo EP at a dose of 1 mg per kg. Have you used this combination? How comfortable are you using this combination? Dr. Abhishek Sharan, do we have you? Okay. Dr. Abhishek Sharma, if you can take this question, please.
Yeah, sir.
Yeah.
So definitely, sir, this study Nivo versus Nivo ipilimumab in our MMR deficient patients. When you look for this study is very well designed. When you look for this study accrual, one catch is there. There are around 300 or 400 patients. That is a skin failure. I don't know what the reason behind that. And after that, you can clearly see there is a well separation of curve when you compare monotherapy versus dual IO. There is a good separation of curve at PFS as well as in OS also. And you cannot go for a trial comparison when KN117 versus Nivopril dual IO. But yes, when you see the toxicity part, yes, this is almost similar in single IO. But yes, in a real world, we definitely say that dual IO has a more adverse effect. But when you do a trial comparison, side effect is quite manageable. OSPFS is quite well separated when you compare with the single versus double. So yes, this study is quite good, and I'm happy with the result. And definitely, those who are affordable, I can use this study.
I think that's a fair point, Dr. Abhishek Sharma. So, one of the things which 8SW did was talk about the treatment discontinuation rates. The treatment discontinuation rates are actually 9% in the
Yes.
BP combination. So,
Yes.
that is some food for thought for us. But let me try and advocate for Nivo EP. Dr. Rahul, when would you want to give Nivo EP together? Is there any particular area or subset when you would want to give Nivo EP together?
So,
Rahul? Yeah.
yes, sorry.
So when would you want to give Nivo EP together? I'm for BMS now. So I'm asking you, pick up at least, I mean, pick up maybe one or two scenarios wherein you would want to give Nivo EP and not Pembro.
So, sir, if the patient is young, fit, a disease burden is high, and he has a good pocket where he can pay payment, the funds, yes, I can choose Nivo EP. But in all other cases, I think Pembro would be my go-to drugs.
So Dr. Siddhartha made this point very clearly. We should never do cross-trial comparison. But if I really want to nitpick, one of the things which HSW showed us was that patients who had a liver metastasis,
Yes.
they actually tended to do better on Nivo EP. That was one subset. The other subset was that, as compared to KN177, the patients with liver mets tended to do a little worse. That was one. The second one, if I remember correctly, KRAS mutant patients. So patients who had KRAS mutation, maybe their outcomes were slightly worse off if we gave Pembro versus the data from 8HW. So if we really want to nitpick and see where we can add Nivo and EP, maybe in those two subsets. But I think, I agree with all of my experts over here. There is a wealth of experience in using Pembro. We are happy with the efficacy. We know how to manage the drug, and financially also it makes a lot of sense. So I think for now, Nivo EP has still not won the race yet, if I can say that. Moving on to the Dragon 01 trial. Now, I'm not sure how relevant this is. So let me start with you, Dr. Siddhartha. To believe that in gastric cancer is stage 4, or do you believe in hyping in this setting?
I consider this as a metastatic setting only, stage 4. But there is some data, like sometimes people give HIPAC and they have shown results, but we generally in our practice we consider this as stage 4 directly.
Dr. Abhishek Sharan, any differing views on this point?
Sir, in metastatic setting, I would say IV would be better, but if disease load is, it can be considered as one of the option, but not much, inclined towards intraperitoneal.
Okay, so you are also not for HIPAC. Dr. Abhishek Sharma, which way
Yeah,
will
sir.
you go?
Yeah, so definitely for this study, one thing I want to say that their standard of care arm, this is paclitaxel. I think that the time of they started accrualment, so paclitaxel alone is not a good choice for gastric cancer. Definitely, all of us are agree for a metastatic patient, first line adenocarcinoma, we are using triplet or doublet. In even as well as right now we have a quite good data with squamous also triplet versus doublet. But yes, this is a suboptimal or substandard line they're using. And intraperitoneal chemotherapy, definitely on this data, I'll choose for the patient those who have a very low burden disease in the peritoneum. And after proper surgical evaluation, that can be converted for the surgery CRS. So those patients can be select for the disease, otherwise no for everyone.
Great. I would have loved to have a surgeon here, but some of the biggest surgeons, at least from Bangalore, are great vocal proponents of HIPEC, especially in colorectal and in gastric cancer with peritoneal mets only. Anyways, let's not go into that. Dr. Rahul Rai, any thoughts on this study before we move on to the next study? Dr. Rahul, are you around?
They should have considered to compare it with triplet regimen if they are considering this as a new adjuvant. That is one of the point that
Be
that I
fair, I mean that was my exact same thought. If you're taking this as a new adjuvant, then you should have done that. So I fully agree with you over there. The second last study of Neo, I want your general opinion on this. Let me start with you, Dr. Abhishek Charan. Dr. Abhishek, have you ever offered a non-surgical approach to a patient of mid or lower rectal cancer?
Yes, sir. Yes, sir. We considered, but eventually patient did not. I mean, there was always a fear that disease may come back, and they were not sure. So as of now, I am not able to get anyone on totally TNT. I mean, neoadjuvant, but I very good option, and we should consider doing it often.
So, Dr. Abhishek Sharma, in whom would you offer a completely surgery-free approach? If I would say that, okay, pick and choose an ideal candidate, what would be your ideal candidate?
Yeah, consider those.
I think even Dr. Abhishek's network is not great. Dr. Rahul's network was not great. Dr. Abhishek, I think you're also struggling with network, I guess. So Dr. Siddhartha, let me come to this with you. In whom would you pick a surgery-free approach?
So in those patients where the organ preservation, the sphincter preservation is very difficult, and they are not they not willing for stoma. In those patients, generally, I would go for non-surgical approach. But in upper and mid rectum, I am going to counsel the patient that you should better go for surgery. So, like, I don't prefer non-surgical approach in those patients at least.
So what is your go-to TNT approach here? Long course, short course, how many months of chemo, first chemo, then CTRT? How would you do that, Dr. Siddhartha?
So for me, it is long course CTRT followed by 5 cycles of capox that is there in OPRA trial where they have
Okay.
given CTRT followed by consolidation NACT. So the same approach I generally follow.
Dr. Abhishek Charan, anything different?
Sir, I same also rapido I prefer, so I go for that short course.
You go the rapido way. Okay, great. So that is still something that we need to, in any you think ctDNA can be used for decision making in this kind of a setup?
So I
Yes,
think
sir.
that data for it is not very clear because many patients who have negative ctDNA have also relapsed. Many patients who have positive ctDNA may not have relapsed. So it is very confusing to interpret actually how much it is going to help. But sometimes during counseling the patient where we have some intuition that we don't want to give chemo, it just helps me just to reinforce my decision that ctDNA is also negative. But I can't say at this point that it is a very sure shot biomarker.
Dr. Abhishek Sharan, you are saying something. Your thoughts on
Sir,
this?
sir, I think it will be a game changer in coming years. We already started using it in few patients, but mainly in as a follow-up as of now. And we picked up one patient who had I mean, ctDNA was rising after surgery, and the patient eventually we started on the chemotherapy. So I think I mean, it will be a game changer for coming years. As of now, it is evolving, sir.
I think I agree with my experts here. It's safe to say that we need some more data. Probably it's a evolving field, but things will change in the next few years in this space. I think, yeah, that completes my panel discussion. I thank all my panelists for their fantastic participation. Thank you so much.
Thank you, Dr. Aditya Murli. And it was a nice discussion to highlight the various topics we have discussed in the abstract. And your moderation was excellent. So thank you very much. And I would like to thank, just a minute. I would like to thank Dr. Abhishek Charan, Dr. Abhishek Sharma, Dr. Rahul Rai, and Dr. Manish Gautam, Dr. Siddharth Tudkar. Now I will move to the session where the Dr. Sushant Mittal is going to speak.
Sir, we
Sir,
request
sorry
you.
to, yeah.
Yeah, sir, we request you to continue with your talk. Actually, Sushant sir is seeing a patient, so he will be joining
Okay.
later.
So can you, okay, I will share my slide then, right?
Sure,
Okay,
sir.
just a minute. We'll share the screen. Can you take the control of this? Hello?
Hello. Sir,
Yeah,
you need to share the slides to me. Just share it to me, then I will share from my side.
okay. No, but it's visible on the screen or not?
Yeah, it's visible, sir. Just make it full screen.
Okay, it is full screen from my side, but the sides are moving or not. You please suggest me it's moving.
No, sir, it's not moving actually.
Okay, every time this happens. I will share by the mail or what? Do you have the mail of the slide?
Yes, yes, sir. Please share it on WhatsApp also. Is it? It's okay.
Varangi, do we have Dr. Asim Samar's slide?
I will finish it fast. Okay. Make it full screen, please. So today's my topic is to discuss the targeting the HER2 new pathway in the gastrointestinal cancer. As you all know, start from the beginning of the intestine, like esophagus and gastroesophageal junction, and then later on, this particular pathway is active, and we are continuously increasing the reports, getting the reports of HER2 positive disease in various settings, whether it is neoadjuvant setting or in the metastatic setting. This pathway is active, and now we are going to target it. And very recently, we have the various clinical data about this. So we will discuss this. Next, please. We'll move a little bit fast because we have 49 slides. So upper GI tract cancer, pancreatic cancer, biliary tract, esophageal cancer have high morbidity and mortality. This is a complex where we see the hepatobiliary system and the gastroesophageal system. They have the high mortality because they diagnose in the later stages, and their progression is very fast, and they usually in the advanced stage. Sometimes they spread in the peritoneal surfaces also. So the prognosis is poor. And next generation sequencing is revealing targetable pathways. It might change the natural outcome of the disease and our treatment also. Next, please.
Sir,
Next.
requesting you to please turn on your video.
Hello. Can you move? Yeah. Whosoever is doing the thing, please do it fast. So biomarker testing is a gastroesophageal cancer. Test result, we can have the HER2 amplification by ISC or by the ISH, and MSI high or DDMR testing. MSI we do with the NGS, DDMR with the ISC, PDL examination by the ISC, NTRK fusion. Some very few reports we could get the positive. Comprehensive genomic profiling, CGP, it is the, you can say, the treatment or the diagnosis now which is emerging, and it is rampantly we are using. When should testing occurs and for whom? All newly diagnosed patient. So we should try for doing the HER2, at least HER2 positivity by the ISC, MSI and PDL1 testing, and if possible CGP is the best answer for all the things. Next, please. So 23 to 60% of the gastric cancer PDL1 positive. So it can, my video is on. Yeah, can you see
No,
me?
sir. No, sir.
Okay, just a minute. If you can see.
Yeah. Please continue.
Okay. So PDL1 in gastroesophageal cancer, it is 23 to 60% patient of the gastric cancer are PDL1 positive, and higher responses to PDL1 inhibitor in gastric esophageal cancer with the higher PDL1 levels, pembrolizumab indication based on the specific levels. So we all know like CPS scores are very important to know how the immunotherapy will work. So next, please. Actually, I am doing from the two. Next, please. Yeah. So this is, I will skip this slide because it is very common. Breast biopsy and the GI cancer, GI tissues also graded in the same way. 0, HER2 0, 1, 2, and 3. So 2 is the equivocal, needs to confirmation with the FISH test. Next, please. And this is the histopathological view of the IC. First, A block is for HER2 negative, where you cannot find the brown color, and B is negative 1 plus. So very rare cells are positive or sparingly stained with this HER2 antibody. Equivocal is 2 plus, and the positive is completely or continuous staining of the basal membrane of the cells. So it is HER2 3 plus is unequivocally positive, and otherwise 2 is equivocal and 0 and 1 is negative. Next, please. Next. So this is the trastuzumab indication. So we are concerning about the gastric cancer and the GI cancer. So in the last block, you can see in combination with the capecitabine or 5-FU plus cisplatinum, we can add the anti-HER2 therapy, that is trastuzumab. Next, please. So RTOG 1010 trial, where the trastuzumab was added to the trimodality treatment. What is trimodality? Is chemotherapy, radiation, followed by surgery. So this was the standard of care for the pretty long period of time. Now, if the patient is positive for the HER2 biomarker, we can add the trastuzumab. Next, please. So trastuzumab was added in the very pretty similar doses where how we use in the breast cancer, but this didn't show the impressive overall survival benefit. Median OS with the trastuzumab was 38.5 versus 38.9 months. So it was a kind of negative study. There was no benefit of adding trastuzumab in the chemoradiotherapy arm. Next, please. Next. So this is the important study where checkmate 577 adjuvant nevo following neoadjuvant chemoradiotherapy was tested in the resection of the esophageal and GE junction tumor. You can see the nevo where the adjuvant nevo was added in the residual disease situation. The nevo arm has done very good. HR ratio for the disease-free survival was 0.69 and the p-value was highly significant, 0.0003. That means you can see the 31% of the patient were benefited with adding the nivolumab in case we found the residual disease after CTRT. So wherever you find a residual disease or in the nodal disease, we need to add the nivolumab and it can improve the overall survival. Next, please. So this is the simplified first-line treatment algorithm for advanced gastroesophageal adenocarcinomas. If no biomarker positive or HER2 negative, then it's a 5FU or capecitabine plus platinum plus minus nivolumab depending on the residual disease. And if it is HER2 positive, then you can use the 5FU based platinum doublets plus trastuzumab plus minus pembrolizumab. So Keynote 811 study is exploring the addition of the pembro to the chemotherapy and trastuzumab combination. Esophageal gastroesophageal junction tumor, the lower end of the esophagus and the GE junction tumor, 5FN platinum based chemotherapy and nivolumab, where the CPS score is more than 5 and especially if it is more than 10, it is beneficial. And fluoropyrimidine plus platinum plus minus pembrolizumab in Keynote 590, where it was tried and it was found to be useful. And here it is HER2 positive tumor. So 5FU plus cisplatinum, trastuzumab plus minus pembrolizumab. Next, please. Next. Yeah. So FDA approved indication for the Nivo and pembrolizumab in the advanced gastroesophageal cancer. We'll check the time also. So you can see pembrolizumab unequivocally approved in the gastroesophageal cancer where the HER2 positive, locally advanced, unresectable or metastatic disease is there. It can be used with the fluoropyrimidine plus trastuzumab and pembrolizumab combination. It has shown the significant survival advantage. Esophageal cancer where platinum and 5FU was used, and if the CPS score is more than 10, in the squamous cell carcinoma, it is approved in the first-line therapy. If patient has MSI high or MMR deficient tumor or TMB more than 10, MSI or MMR tumor, as we all know, wherever it is found, according to the basket trial, you can use the pembrolizumab as a single agent. Nivolumab is especially approved in the advanced or metastatic GE, gastric and GE junction tumor in the adenocarcinoma with the fluoropyrimidine plus platinum containing doublets. And unresectable advanced metastatic esophageal or squamous cell carcinoma in first-line therapy, you can use with the combination of the 5FU cisplatinum or with the ipilimumab. Next, please. Next. Yeah, so you can see the trastuzumab, pertuzumab for HER2 new amplified BTC tumor, related cancers. It is not very impressive because we can see the waterfall plot. Almost you can see the CR and CR was not there. PR and stable disease is you can see the numbers are not very impressive. Next, please. Next. This is the Genidatamab, where HER2 targeted. It is a HER2 targeted bispecific antibody, and it targets both the HER2 epitopes. there are trastuzumab for ECD4 and pertuzumab for ECD2. So this is the combination of both, and it was well tolerated in the preclinical studies, and in the breast, gastric, and ovarian cancer, still to be discovered. Next, please. Yeah, this is a waterfall plot. You can see the partial response was there in the 8% of the patient, stable disease in the 5 patient, and the progressive disease in the 7 patients. So median duration of response was 7.4 months. Under exploration, but still it is not a very effective therapy. Next, please. It was phase 1 only. So you can change this slide, please. Next, please. We have already discussed this. Next. HER2 positive, HER2 esophageal gastric cancer is not a breast cancer. In first line therapy, trastuzumab approved in first line according to TOGA trial. CAP cis plus trastuzumab improved response rate, PFS, and overall survival versus capecitabine plus cisplatin. Overall survival was 13.8 versus 11.1 month. HR ratio was 0.75. It is impressive. First line lapartinib plus capecitabine. You can see the overall survival was 12.2 versus 10.5 months. HR ratio was 0.91. It's not impressive. Jacob trial was failed to improve the shown the overall survival benefit. Next, please. So this is a famous TOGA trial where HER2 positive advanced gastric tumor patients were taken. The N number was 584, quite a large trial, and it was randomized in the 2 subgroups: capecitabine 5FU, capecitabine of 5FU plus cisplatin, or versus the capecitabine cisplatin plus trastuzumab in the advanced gastric cancer. Next, please. And all the drugs are used in the standard fashion. Capecitabine 1000 mg per meter square 2 times in a day, day 1 to day 14, then 1 week off into the 6 cycles. Cisplatin 80 mg per meter square Q3 weekly to 6 doses, and trastuzumab 8 mg loading dose and 6 mg the 3 weekly dose. Next, please. Next. So yeah, here you come with the initial positive study. You can see if you add capecitabine plus 5FU with trastuzumab, the HR ratio is quite significant. It was 0.65. That means 35% patient got benefit in the progression-free survival. Next, please. Next. So how was the TOGA trials concluded? Trastuzumab in combination with the standard chemotherapy aids benefit in terms of the overall survival without affecting the overall safety profile for treatment of the metastatic gastric cancer. New standard option for patient with HER2 positive advanced gastric cancer or gastroesophageal junction cancer, when combined with a chemotherapy regimen. So initially we had discussed like almost 23 to 60% patient of the gastric cancer are positive with the HER2 new biomarker. So if they are positive and you can expose this patient to the trastuzumab along with the chemotherapy arm, they got good benefit of the PFS and the OS. So TOGA trial was important. Next, please. Again, the same thing. Next, please. Yeah, and the HER2-directed therapy in advanced cancer. This is the summary. Apart from this TOGA trial, no improvement outcome in these trials. So the trial Titan, Gets by, and TACT, Jacob, Helios, Logic, they all failed. Next, please. Now, keynote 811, first line pembrolizumab plus trastuzumab in the adding to the chemotherapy in HER2 positive metastatic gastric and gastroesophageal junction cancer. This is an important study which has changed the pathway how we treat the HER2 positive disease in the GI cancers. So, as we all know, the gastric cancers are notorious to have the bad outcomes because of the patient general condition, their nutrition status, and early spread of the disease to the peritoneal surfaces. Sometimes their histology is different, they are mucinous, so they don't respond to the chemotherapy. Now this keynote 811 has explored the new pathway for treating this kind of the HER2 positive tumor. So it was a randomized double-blind placebo-controlled phase 3 study where the patient with HER2 positive advanced gastric or GE junction adenocarcinoma who had not been exposed to the chemotherapy and they were in the advanced setting, they have randomized in the two arms pembrolizumab 200 mg Q3 weekly plus trastuzumab adding to the capox or fluoropyrimidine chemotherapy versus the trastuzumab plus chemotherapy. So basically the question was adding pembrolizumab to the standard arm can improve the survival or not. So it was pembro was given up to the 35 cycles, that means 2 years. Next, please. Next. So first time you can see the overall response rate, the p-value was highly significant. P-value was 0.00006 for the overall response. And the disease control rate was 96.2%. And in the placebo arm, there the trastuzumab also was a part of the chemotherapy. So it was 89.3%. Best responses noticed were CR in the 11% of the patient had CR, 63% patient had PR, 5% of patient progress in the pembrolizumab arm, and you can see the median duration of response was 10.6 months in the pembrolizumab, and you can see the size reduction. It was 97% in the pembrolizumab. So next, please. So it was quite significantly improved the survival, and this is the waterfall plot for the responses. You can see the in the pembro when added to the trastuzumab plus chemotherapy, it has improved the overall response rate, and only 3 or 5 patients had progression of the disease. Next, please. So this is the checkmate 649 where the Nivo EP or chemotherapy versus chemotherapy in the gastroesophageal junctions were tested. So they have randomized according to CPS scoring. CPS score more than 5. So Nivo plus chemotherapy versus chemotherapy. Nivo plus chemotherapy has done fair well, and at the 12-month the progression-free survival was 57% in the Nivo plus chemotherapy arm versus 46 in the chemotherapy. And it obviously it was affected by the CPS level. And median overall survival at the 12-month was 55% in the Nivo plus chemotherapy arm versus 48% in the chemotherapy arm. And at the 2 years, 28% patients were alive in the Nivo plus chemo versus 19% only in the chemotherapy arm. And the HR ratio was 0.79, which is significant. Next, please. Next. So next, please. This is not very important. Next. Keynote 590, first line pembro plus chemotherapy versus chemotherapy for esophageal cancer. If the CPS score is more than 10, we all know it is quite effective to add the pembro to the chemotherapy. The what do you call is CPS, if the overall CPS score more than 10, the overall HR ratio for the overall survival is 0.62. That means 38% patient got benefit in the overall survival. If it is less than 10% CPS score, then it is 0.86 only. Next, please. Okay, so select the novel HER2 directed strategies. Antibody drug conjugate. There is the trastuzumab deruxtecan. US approval for the adult patient with locally advanced or metastatic HER2 positive gastric or gastroesophageal junction adenocarcinoma who received prior trastuzumab based regimen in the second line. Then monoclonal antibodies, margetuximab, zanidatamab, tucatinib, niratinib, numerous other agents. Next, please. So, yeah, we have already discussed this. Next, please. In the interest of we need to skip the slide. Next, please. Next. Yeah, Destiny Gastric 01. So Destiny is a famous trial in the, you can see in the breast cancer arena. Now in the Destiny in the Gastric 01 trial, trastuzumab deruxtecan in previously treated HER2 positive gastric cancer or gastric esophageal adenocarcinoma, HER2 positive locally advanced or metastatic gastric tumor were randomized into 2 arms, TDXT, 3-weekly cycle, and physician's choice chemotherapy. So TDXT was given until the unacceptable AEs, and they were given for the irinotecan was given for the 6 cycles. Next, please. So you can see the TDXD patient, 9 patient had the CR out of the 51 patient. PR had 42, stable disease 35. And the p-value for the oral response was highly significant with the TDXD as compared to the physician's choice chemotherapy. It was 0.0001. So it is approved in the second line after you have used the trastuzumab with the chemotherapy arm. Confirmed disease control rate was 86% versus 62% only in the physician's choice chemotherapy. And next, please. The duration of response was 12.5 months versus 3.9 months in the chemotherapy arm only. So this kind of the graph we want in our clinical practice. Destiny 01 trial, they have shown like HR ratio for the oral survival was 0.60. That means 40% patient had benefit with the TDXD arm as compared to physician choice chemotherapy, and for PFS it was 40.47. That means almost 63% patient had got the PFS benefit with the TDXD. Next, please. So we all are thinking like it should move in the first line. Destiny gastric 02 trial, trastuzumab deruxtecan in the HER2 positive advanced gastric cancer after first line trastuzumab. This is the phase 2 trial. I guess disease control rate was 64% and the duration of response was 8.1 month in the second line therapy. Next, please. The still it is very good. Next. And you see the gastric 02 where it is used in the second line. Waterfall plot has shown like only few patients don't respond. Otherwise, every patient responded with the TDXD therapy. Margetuximab, you can skip this slide. Next. Next, please. We are skipping because the drugs is not available in India. Next, please. Next. Move 3 slides. Yeah. Next. This we have discussed. Next. Yeah. Next. Yes. So select investigation HER2 target agent for advanced gastroesophageal cancer. This is the mechanism of action is HER2 targeted murin antibody margetuximab, and oral response was only 29%. PFS was 5.45 months and overall survival 14.62 months. And HER2 targeted bispecific antibody jenitumab, So oral response was 33%, Gen plus Pacli was 50%, and Gen plus K was 57%. Next, please. This is a summary of the slide. Next. All the trials they have summarized. You can skip this slide also. Next. Yeah. So HER2 in the HER2 positive tumor, what are the second line negative trials? Trastuzumab emtansine, this is TDM1, not better than the taxane. T8 phase 2 continuation of the trastuzumab into the second line. Pacli plus minus trastuzumab, there was no overall survival benefit. Right. Next, please. Next. Okay, summary of this talk is HER2 positive represents the first validated target in the gastric and the gastroesophageal junction tumor in the adenocarcinoma. All patients with metastatic gastric and gastroesophageal junction tumor adenocarcinoma who are HER2 positive should be considered for trastuzumab based chemotherapy in the first line, and if you can avail the second line deruxtecan TDXD, it is better. There are few data on the use of trastuzumab in pre-operative or adjuvant setting or its continued use after progression on trastuzumab based chemotherapy, that you can change the partner. Drug development targeting HER2 in the gastric cancer is active and ongoing. Next. So thank you for very much for your patient listening, and now I would like to invite Dr. Sushant Mittal for his talk on the transforming patient outcome with the newer innovative therapies in first line advanced metastatic HCC. Dr. Sushant. Thank you, Dr. Sushant, for joining us. I heard you were busy in the clinic.
Thank you for inviting me. It's always a pleasure and great talk by you. And I'll be now shifting the gears to HCC. Can you please share my slides? We all now know that HCC The number of patients are gradually increasing, and the older therapies such as sorafenib were not that much effective. Next slide. But the advent of newer immunotherapies, with the advent of IO therapy, with the advent of immunotherapy with targeted therapies, the overall survival and PFS has improved. Liver cancer is the 7th most common cancer and 4th most frequently cause of cancer-related death globally. Next slide. 45% of the patients are diagnosed when it has spread to lymph nodes or metastatized, and the prognosis is poor. We can see from the histogram that advanced stage, the overall survival is much less. Next slide. Hepatocellular carcinoma in India is also on the rising trend. Majority of the patients are male, with incidence of about 38,000 per year, and deaths is about 36,000 per year. Next slide. Inflammation and immune dysregulations are the common underlying etiopathogenesis. Next slide. This inflammation can be because of alcohol, viral, or metabolic causes, which leads to chronic inflammation, leading to cirrhosis, leading to HCC. Next slide. Next. Nowadays, we are seeing that non-alcoholic steatohepatitis, NASH, is a common cause in teetotalers, in viral negative patients, because of increasing obesity, diabetes, and blood pressure. Next slide. Next. So this is the category in which various HCC stage patients are treated. What we'll be discussing is unresectable hepatocellular carcinoma, that is, which are not amenable to local therapy and are require systemic therapy. Next slide. Since Dr. Asim and me were resident, we have been using sorafenib. Then came regorafenib, and more than a decade there were no new drugs. But now we have lenvatinib, pembro, cabozantinib, ramucirumab, and the drugs which have changed the scenario are atezobev and tremi-durva. And what I'll be discussing is IO-based chemotherapies, IO-based immunotherapies. Next slide. Based on the SHARP and REFLECT trial, it was clearly proven that sorafenib did show overall survival benefit. Lenva versus sorafenib, there was not much of a difference, and both were considered targeted therapies. Even today, for patients who are not able to afford immunotherapy, sorafenib or lenvatinib is commonly used. I think lenvatinib is much more commonly used because REFLECT trial has shown that lenvatinib is non-inferior to sorafenib, and it is much more easier to be given and tolerable compared to sorafenib. Next. Next. So IMBRAVE 150 study proved that IO with anti-VEGF inhibitors, that is atezo plus bev, compared to sorafenib, next slide, showed that overall survival benefit was there in patients. Next. The graphs did show that the overall survival was in the tune of 10.2 or 19.2 versus 13.2 with significant p-value, and the median PFS was 7 versus 4.3. So not only OS but PFS was also shown to be improved because of the IO plus VEGF therapy. Next slide. The subgroup analysis also showed that irrespective of the etiology, irrespective of the age, performance status, these patients benefited. Nonetheless, non-viral HCC, that is NASH HCC, if we see that the diamond is much more near the unity, and these patients did not benefit much with atezo-bev combination. Next slide. It's a well-tolerated regimen. Most common side effects being hypertension and proteinuria. Next. Next slide. So the rationale of combining IO-IO combination, that is anti-CTLA-4 with anti-PD-L1, was that anti-CTLA-4 activates the lymphoid compartments and hence increases the T cell, and PD-L1 improves the microenvironment in which T cells can work in a better way, and hence a synergistic anti-tumor activity is seen. Next. So Durva plus Tremi working in synergy, which increases the anti-tumor activity by reversing the T cell exhaustion and allowing T cells activation respectively. Next slide. Now, why single dose is better than the persistent interval dose? I'll tell you in the next slide. Next slide, please. So this was the trial in which it was the durvalumab with Tremi, different doses of Tremi was given. Next slide. And ultimately it was seen that the anti-CTLA-4 Tremi 300 mg significantly improved the activation of T cells and intermittent dosage was not required. Hence, the STRIDE regimen was defined as the highest efficacy compared with Durva Tremi as monotherapies, or the Tremi dose of 75 plus Durva. I was part of this trial, and ultimately it was decided that single dose of Tremi was sufficient enough along with Durva. Next. So hence this Himalaya trial was launched. It was an phase 3 open label multicentric study in which Tremi plus Durva was given in unresectable HCC. Next slide. So it evaluated the effect of IO therapy in treatment naive patients with BCLC B and C with no prior systemic therapy and childhood A with good performance status. Next slide. This I have already told. Next slide. The demographic profile, the patients were equally balanced between the three arms, and majority of the patients were male, with non-viral etiology patients being 40% and rest B and C being equally divided. Majority of the patients were childhood A. Next slide. So this regimen showed and met its primary endpoint of overall survival, which was 33 months versus 32 in sorafenib, with significant p-value. And as the patients improved at the end of 3 years, there was around 10% additional patients who were alive because of the STRIDE regimen. Next slide. Subgroup analysis included all patients, and it is well tolerated regimen. Next slide. The response rates were 20%. Even 3% patients achieved CR and majority achieved the partial response. The duration of response was nearly about 2 years. Next slide. It is a well-tolerated regimen. Immune infusion related effects are seen, but it is managed, and with high dose steroid, only 20% of the patients required steroids for this management. Next slide. As I told you, most common side effects were rash, pruritus, and diarrhea, and hand and foot syndrome, but they were well managed. Next slide. The important point is that treatment related hepatic or hemorrhagic events were much less with the Tremi-Durva arm. I'll be telling you in a while why I'm talking about this. Next slide. The 5-year overall survival OS benefit was also presented in ESMO. Next slide. And it showed that at the end of 5 years, 19.8 patients were alive compared to 9% on sorafenib, and hence the patients who continued to show response did very well even at the end of 5 years, which is unheard in unresectable HCC. Next slide. The updated 5-year overall survival as per the forest plot and subgroup analysis also showed that all variety of patients which we see in our OPD practice benefited from this stride regimen. Next. Irrespective of the etiology, in non-viral etiology is also this the patients have benefited, although cross-trial comparison should not be done. But in atezo-bev regimen, the NASH people or non-viral etiology did not benefit. But in this category of patients, which is a rising incidence, is rising etiology of HCC, these patients benefited with this stride regimen. Next. Next slide. So in ESMO 2024 ESMO Asia, again the 5-year overall survival was presented, and it did show that patients across all the subgroups benefited with the stride regimen. Next slide. We can see that the end of 5 years, patients on stride regimen, the 60-month OS 24 versus 13%, and patients are doing well. Next. And hence NCCN also suggests that Tremi Durva is a category 1 recommendation. Next slide. So to conclude, HCC is one of the topmost cancers for affecting Indians. There is a shift from viral to non-viral etiology. The stride regimen sustained OS benefit and sorafenib and demonstrated an unprecedented long-term overall survival, 19 versus 9.4. It sustained the benefit regardless of the liver function. Stride maintained the tolerability side effects in both LB subgroups. There was no additional concerns. Again, in all subgroups, the patient benefited. It maintained the tolerable and differentiated safety profile from the current available therapies. And it continues to show a benchmark in unresectable HCC. In my practice, in patients who have high risk of bleeding, I do not prefer atezo-bev, and in those category of patients, we can use this regimen, although it is one of my patients, we can use irrespective of the bleeding. If the patient does not have a bleeding risk, then also I have used Durva and Tremi, and the patients have done fine. Thank you so much for your patient hearing. Back to the organizers.
Thank you, Dr. Sushant, for sparing time for us. And it was a wonderful talk. And you have shared your personal experiences also. That was good. And thank you very much, Dr. Sushant Mittal. So now we are at the end of this webinar, first day. And I would like to thank our tech team support. Would like to thank our pharma partners, academic partners who have supported us. And I would like to thank our esteemed panelists and doctors who have given their inputs and their experiences. And actually, personal experiences, when shared, they becomes the knowledge of everyone's. So, in the on the screen, you can see our academic partners were AstraZeneca, Cipla, Reddy's, Dr. Reddy's, Merck, Fresenius Kabi, Delarc, Bayers, Glenmark, Natco, Izai, Samarth, and Ferring. So thank you very much for supporting us, and we'll be meeting tomorrow also for the other wonderful discussions. Thank you very much, and good night to all of you. We exceeded by 15 minutes. Thank you very much. Thank you, team
Thank you,
support.
sir.
Yeah, we'll meet
Thank you
tomorrow.
very much. Thank you, everyone, for joining. Thanks to our academic partner. Thanks to my colleague Dhruv and Sarangi and the technical support. Good night, everyone.